Welcome everyone to the Children's Safety Network webinar, Using Quality Improvement to Prevent Childhood Injuries. We'll be talking today about strategies from the Child Safety Collaborative Innovation and Improvement Network, more commonly referred to as the Child Safety CoIIN. My name is Jenny Stern-Carasone. I am one of the co-managers of the Child Safety CoIIN, and I'll be your host today, guiding you through today's event. A few tech tips to get us started. All audio is broadcast through your computer speakers, so all communication needs to be done through the Q&A pod. If you experience any audio issues, please dial the number you see here and be sure to mute your computer speakers as you join. The Q&A pod located to the left is available for you to ask questions at any time. We will be referring to those questions predominantly at the end of our event during our Q&A session, or we'll respond to anything that needs immediate attention. You can download resources from the file share pod above. And again, all lines are muted if you're calling in on the phone line. Otherwise, all audio is broadcast through the computer speakers. This session is being recorded and will be posted on the Children's Safety Network website following the event. Today, our agenda and objectives are to share the project purpose of the Child Safety CoIIN, what our approach is, and to hear some team stories from some of the strategy team members from the various topics within the CoIIN. We'll then have time to address your questions and have some other discussion and shared information. We have many different wonderful presenters today. We'll be hearing from all of them throughout the course of the webinar. And so that we don't lose time, I'd like to start off right away by introducing our first presenter, Becca Thomas. Becca is the director of the Children's Safety Network Child Safety Collaborative Innovation and Improvement Network, and as I said, we refer to this as the CoIIN. Becca has worked in the field of violence and injury prevention since 2007 at a variety of governmental, nonprofit, and international organizations, including Boston Public Health Commission's Division of Violence Prevention and the United Nations Development Program, Bureau for Crisis Prevention and Recovery. Becca is going to share the purpose of the Child Safety CoIIN at this time. Becca?
Thank you so much, Jenny, and it's great to be with you all today. We've been working very hard on the CS CoIIN for the past couple of years with our state partners, and it's exciting to be able to share some information with you all. So I wanted to give you a little bit of a background on how the CS CoIIN came to be. So starting a couple of years ago, HRSA noticed that there was I'm sorry, my slides are being a little finicky and they're not letting me advance very well. So we noticed that there were more children and adolescents ages 1 through 9 dying from injuries and violence than from all other diseases combined. On the screen you see the pyramid, which shows that while there is a large number of deaths, the rate of hospitalization and ED visits is even greater. So recognizing this as a problem, we began to look into the leading causes of injuries among this age group. And what we saw was across deaths, hospitalizations, and ED visits, there were common patterns where motor vehicle crashes, homicides, suicides, falls, and interpersonal violence were all leading causes of deaths, hospitalizations, and emergency department visits. And we knew that there was evidence that exists to prevent these types of injuries. The Children's Safety Network has been around since the early 90s, and we've done a lot of exploration of best practices in preventing childhood injuries. There's a lot of cost analysis and cost data, so we began digging into the data even further. And what we found was over the past 15 years or so, we've seen that these evidence-based practices have been used and are showing reductions in death rates, for example, from motor vehicle crashes. The pink line on the screen is deaths among teen occupants in motor vehicles. And you can see that it's gone downwards pretty rapidly over the past 15 years. And although these other lines are flattened somewhat, and we do see an increase in suicide and death rates, we do know that some of these numbers are also trending downwards. We saw similar trends with hospitalization rates as well as emergency department rates, where many of these numbers are trending downwards, but some of them are flat and some of them are going up. And looking into the data even further, we saw that there's gaps. There are gaps in implementation of evidence-based practices, gaps and disparities among different ethnic, racial, gender, sex, etc. So here we see the rate of injury hospitalizations broken out by male and female, and we can see that self-inflicted injuries occur much more commonly among females, while males make up the majority of falls, unintentional struck by and against, and motor vehicle crashes. So we know that there's gaps in what works and what's working with male populations and female populations. We see similar trends with rural and urban areas. So we see self-inflicted injuries occurring more in urban metro areas, and we see falls occurring more in urban metro areas where motor vehicle occupants are being hospitalized more in rural areas. So we know that this is pointing to another gap in what works in these populations. And likewise, we saw the same thing when we looked at the breakdown of race and ethnicity. So here we see that whites often are experiencing more injuries, but Native American, Alaskan Natives also have high rates. So this pointed us to the fact that there are gaps in what works in injury prevention and what's being implemented across the states. We looked and saw that some states are actually seeing greater reductions in injury from the 2007 to 2009 group and the 2013 to 2015 group. So between those two spans of time, the District of Columbia had a 52% reduction in fatal injury rates, whereas Montana had a 0% reduction in fatal injury rates. So we wanted to see what was happening in those states that were experiencing large reductions versus states that were experiencing no reductions or very small reductions. So to move the needle in childhood injury prevention, we know that the field needs to integrate evidence-based child safety practices into relevant care settings, forge collaborative partnerships across silos and state lines, streamline child safety messages and activities, and increase the adoption of effective child safety interventions at state and local levels. So that's where the CoIIN began. And we chose to boldly focus on those 5 leading causes of childhood injuries: teen driver safety, child passenger safety, falls prevention, interpersonal violence prevention, and suicide and self-harm prevention. This is to lead us in the direction of more broadly implementing evidence-based practices to prevent childhood injuries. I'll pass it back over to you, Jenny.
Great, thank you so much, Becca. Now we're going to move into talking more about the approach, and I'd like to introduce Jen Leonardo. Jen is our Quality Improvement Advisor and co-manager of the Children's Safety Network Collaborative Innovation and Improvement Network. Jen brings over a decade of experience in public health and social work program development and evaluation, as well as capacity building and facilitation to this position. And Jen is a vital member of our CoIIN team. Jen?
Thank you, Jenny. I'm excited to talk with you a bit today about the CoIIN approach. We are using the Institute for Healthcare Improvement's Breakthrough Model Series, and we're also using Associate in Process Improvements Model for Improvement. The Breakthrough Series is an organized structure that allows us to have states and jurisdictions come together through 3 learning sessions where they learn about quality improvement approaches and they share lessons they're learning, barriers that they're facing. We provide technical assistance to the states and jurisdictions. In between those learning sessions, we have monthly topic calls to add additional support and to hear and learn from the states and jurisdictions. And what was really the heart of this approach is this model for improvement. So there are 3 key questions, and then there is a framework for learning, the Plan, Do, Study, Act cycle. And I'm going to go through these 3 questions and this framework in the next slide. The first question is really the aim statement. What are we trying to accomplish as a CoIIN? So what is that shared aim around injury prevention? The second question is, how will we know that a change is an improvement? What are those measures that we can collect data on that will allow us to see if there is a signal of improvement? So if there is a signal of improvement, we know that we would want to continue that good work or maybe test some more ideas out to get that measure to reflect even better signals of improvement. Or if it's going in the other direction, we would say, okay, what we're doing isn't quite working. Why? And that third question, what change can we make that will result in improvement? That is the work itself. So what are those evidence-based ideas that we want to start translating from research into practice? The shared aim statement for the CoIIN is that by May of 2018, we will reduce deaths, hospitalizations, and emergency department visits resulting from child passenger safety, falls, interpersonal violence, suicide and self-harm, and teen driving in children ages 0 through 9 and in adolescents ages 10 through 19. And we specify goals for these three outcome measures. We're looking to decrease the rate of injury-related mortality by 5.83%, looking to reduce hospitalizations by 3.81%, and decreasing the emergency department visits by 3.74%. And these percentages are relative to the participating state and jurisdiction baseline data. The second question in the model that I showed you, how will we know that a change is an improvement, is talking about the measurement strategy that we have for the CoIIN. And we have three levels of measures. The first level, the outcome measures, is what was presented in that aim statement: fatalities, hospitalizations, and emergency department visits. The next level, which is more of the intermediate level, would be your process measures. So for each of those 5 child safety topics that we have a respective measurement strategy, and we have process measures for those. We provide up to 20 process measures per topic area. And we ask states and jurisdictions to look at the work that they're going to be undertaking, the strategies, the practices, the programs that they're going to be testing and implementing, and aligning those with some indicators, some measures. We offer flexibility in the measures, so we're intentional in offering a larger number of process measures for states and jurisdictions to select from. And we do this because we know that there are different barriers to data collection, either accessing data, be that organizational data or participant level data, and we want to make sure that in a quality improvement approach that you're really just collecting what is sufficient. So it's not a traditional research approach where you're looking for full and complete information, but rather looking for sufficient information that will give you confidence that what you're doing is working and that you have some signals of improvement to move forward. If states and jurisdictions find that they are not able to locate 5 to 7 measures that really make sense for the work that they're doing, we'll work with them to develop a measure that makes the most sense for them. And we've had that happen in the first cohort of this CoIIN. Another interesting piece on the measurement strategy is that with intentionality, we have flexibility in terms of the quality, if you will, of the measure. So we have some implementation measures, which would read something like the percent of teens educated on graduated driver's licensing. So what's that percent of teens that you trained or educated versus a measure that is a little bit more downstream that is getting at changed behavior. So that would be a harder measure to be collecting and following. But the measure there would be the percent of teens reporting influence of alcohol or substance use while driving, or the percent of teens that report speeding, or percent of teens reporting driving with teen passengers. So we have a real menu available to our states and jurisdictions. And then we have measures that really just pertain to learning cycles, and I'm going to get into that in just a few slides. Those are the PDSA measures. So here is just a question that we ask when we think about the third question, which is, what's the work? What change can we make that will result in improvement? So we ask this question, if I want to achieve a particular outcome, a reduction in deaths, hospitalizations, or emergency department visits, I need to focus on some drivers, some strategies. And one way or ways to achieve those drivers is to focus on testing and implementing and spreading these evidence-based change ideas. So we provide Word documents or PDF files of what we call change packages, and I'll show you a little example. And in those change packages, you have your aim statement for your topic team, and then you have your theory of change, which we call the driver diagram. And states and jurisdictions will look at that, and they will select what makes sense for their state. So here's a little sliver of one piece of the teen driver safety driver diagram. So following that logic, a state or jurisdiction could say, if I want to achieve this outcome of reducing teen fatalities from motor vehicle crashes, I need to focus on this particular driver, which is enforcing graduated driver's licensing policies. And one way to do that is by testing this evidence-based change idea, which is to leverage incentives for completion of teen driver safety programs and interventions. You'll see on the slide in front of you, this is highlighting just one section of the teen driver safety driver diagram or theory of change. So it's a theory of change because we are testing it. States are taking these evidence-based change ideas that you see on the right-hand column, they're putting them into practice, and they're providing us with feedback as to what is working and what is not working, and then we make revisions to this theory of change at the end of our cohort. And that's what we're doing now as we end cohort 1 and move into cohort 2. So let's take a look here at the left-hand column where we have the primary driver. You'll see it says primary driver 2 organizational level. That's because our driver diagrams are being organized around the social ecological model. So we're recognizing that you really need to be working at different levels of an entire system in order to achieve that larger aim statement of reducing death, hospitalization, and ED visits. So we are going to be providing drivers and change ideas at the societal level, the organizational level, and the individual and relational level. So this example is for the organizational level, and the primary driver is that organizational policies and procedures support the culture and practice of teen driver safety. So that's at the highest conceptual level. So what does that mean? Well, there can be a number of secondary drivers that need to be accomplished in order to achieve that primary driver. And this example of one of those secondary drivers is having enforced graduated driver's licensing policies, programs, and best practices. So you might say, okay, that sounds good, but how do you do that? What actions may we take? So those are your change ideas. So we have a menu of change ideas, and you can read them here. There are 5 on this slide, but states would look and they would select the change ideas that they would want to work on. So they would be asking, what's happening in our state? Where are there gaps? Where do we want more learning to take place? And they would select those change ideas to begin to test on a small scale, get some learning from, and then once they have confidence that these change ideas are working and providing some signals of improvement, they would implement and spread them widely across their state or jurisdiction. So once they select those change ideas, we provide them with a methodology for this trial and learning process. And this is the Plan, Do, Study, Act cycle, which many of you may be familiar with. It dates back, can be traced back to as early as the 1920s and then the 50s, and it's used across a variety of industries, including healthcare, of course. And what it is it provides you with a management structure, a framework to do this smaller scale learning so that you're really balancing going really wide with an idea before you know that it works in practice in your local context with being really small and being paralyzed because you need full information and full analysis of information before you can move forward. So there are 4 steps in this cycle. You plan your work, you identify some questions that you have, and you make some predictions as to what will happen. So this follows the scientific method. And then you go ahead and identify who's going to carry out the cycle, when, where, what will they do. And then you go ahead and you do it. You carry it out, you document what has happened, and then you study it. You analyze your data, and you compare what happened to the predictions that you made, and you summarize that learning. And then you really ask yourself, where do we go from here? Did this work? Should we adopt what we did as it is? Do we need some adaptations to what we did, or did it not really work? Do we need to abandon this? And we do this on a scale that is small enough where the risk of failure isn't too large. So an example here would be in teen driver safety, that the Nebraska strategy team, they decided that they wanted to focus on graduated driver's licensing, and they did some surveys and they found that this information wasn't being readily provided through some resources through the Department of Motor Vehicles that a lot of parents and teens accessed. And they decided they would first come up with a card that had graduated driver's licensing information laid out. And they wanted to test whether this particular information card could increase parent and teen knowledge of graduated driver's licensing. So they ran a Plan, Do, Study, Act cycle where they developed the card, and then they showed that card and they presented a survey to very small samples of teens and parents, around 5 teens and 5 parents to start with. And they collected that information, and they found that they were getting very high numbers in terms of percentages of parents and teens reporting that their knowledge had increased 90%, 100% in these small samples, but they were also getting feedback on that card and what they should adapt. And so they went and they made adaptations and did their revisions, and they sent it out to larger samples and got more feedback, and now they're ready to run more cycles as to how they're going to get this to even wider audiences. And I'll talk a little more about this at the end of this section. So just to recap, I know that was a lot of information, but to recap, in each of those 5 child safety topic areas, we present a change package. And in that change package, which is a document, each topic team was going to have an aim statement. So what are the targets? What are the quantifiable reductions that we are hoping to see in deaths, hospitalizations, and emergency department visits? We look at state and jurisdiction trend data to come up with those numbers. We then ask states and jurisdictions to revise those aim statements based on the work that they're going to be doing. So if it needs to be bumped up or brought down a bit, they are certainly at liberty to go ahead and do that to make it work for their state and jurisdiction. Then in the change package, you have that theory of change, that driver diagram, and that includes the drivers and the change ideas that we went through. And then you have the measurement strategy, and that measurement strategy will provide detail around the outcome measures and the process measures in terms of what is the measure, what is the numerator that should be reported, what is the denominator that should be reported, what is some data guidance around operationalizing that measure, identifying the settings, the populations that you're working in, identifying any key terms, what is the frequency of data collection that we are expecting, and then suggestions for data sources. So what happens is once the work is underway and states and jurisdictions are able to start collecting some data, they submit that up through the CS CoIIN web portal, and then we create run charts for them. And run charts are time series graphs. They're intended to be simple to read and understand. You'll see on the x-axis, we collect data monthly. And then in this example, we have the measure is the % of active stakeholders in the state or jurisdiction teen driver safety coalition. And you have your percentage down the left-hand y-axis. And then you have the number of stakeholders down the right-hand y-axis. And the yellow line that you see on the run chart is the % of active stakeholders. So you can see that there was some variation there through October, and then that percentage started to go up in November and December, and they're hitting about 100%. So they would make some decisions as they continue to work if they're holding these gains, at what point it's enough and they should move on to another measure or other work. The black line there is just a baseline. Because we are early on in the CoIIN, we've taken the first 3 data points and we took the median and we extended that median across the run chart so they have a baseline with which to compare the work that they're doing to. And we have topic calls where they share these run charts and this information with each other. So I want to point out just a couple of the challenges and the work that is done on the ground. So we do know that a challenge in quality improvement work at the population health level is collecting real-time data. There's often a 2 or more year delay before the data becomes available to the practitioners where it's nice and cleaned. But as I said earlier, in quality improvement, you're really looking for what's sufficient to move forward. So you don't want to have the paralysis by analysis and waiting before you can take some action. So we try to really support states and jurisdictions to think about some different innovative data sources they may access. We provide them with some outcome worksheets, encouraging them to work with state and jurisdiction epidemiologists to identify data sources and to come together around a shared operational definition of those measures. We provide them with the ICD codes for those 5 child safety topic areas. And you can see here that we have 5 states that are already able to collect real-time outcome level data, which is really exciting. You'll see Florida has been able to collect data across the 3 outcomes. So we're learning from the states and they're learning from each other and sharing this information. So what we ask the states to do, we provide them with all of these resources and tools, the change packages, the data collection guidance, the outcome worksheets, and we say, okay, let's really start with this being about your local context. We're translating literature and some evidence into practice and learning, continuing to learn. So let's start with looking at what's going on in your organization. What are your strategic initiatives? what are you trying to accomplish, and then what do you want to put through an improvement process. It's not everything. Identify where the gaps are, identify where you want the learning. And this slide just shows a quick example of that, where they may have a number of strategic initiatives down the left-hand column, and then they may say, well, let me pick a few of those and let me put that through this quality improvement process, and let me put it into a portfolio of improvement projects. So I want to leave you with a little more information that talks a little more about the work on the ground once they go and they do their strategic alignment, when they have all the tools and the resources, and they start doing the plan, do, study, act cycles. They think about phases of improvement. So the work's going on the ground, and not everything is at the same phase. So in that Nebraska teen driver safety example, they needed to develop material. They needed to develop that card. So they were in the develop phase. The develop phase is often about developing resources, forging partnerships, building a coalition. So anything that needs to be done to get the work going. But then there are other states that may be in a testing phase or an implementation phase already. But let's stay with Nebraska. So Nebraska now, they have moved into this testing phase where they started to take that card and they picked pilot sites. And they have 5 pilot sites that have teens in the driver's seat programs, and they are running that card through those programs, and they're collecting information from teens and parents, and they're seeing that they had 80% of teens and 71% of parents that reported increased knowledge of graduated driver's licensing. So now they're saying, okay, we have good results from our testing. Let's start to implement this. Let's make sure the gains we made in the schools are sustained. And so they think about, what are those permanent systems? Are there procedures, policies, trainings of staff, job descriptions, anything that needs to be done to support a system that will allow the work to continue? And then the last phase there of improvement is spread. So how do you get it to a wider audience, more organizations, more people? And in Nebraska, they're implementing in schools, but they're also thinking about spread. So these phases, you can be in different phases, and you can be a little bit back and forth, but they're in spread in that they're now working with the Department of Motor Vehicles, which issued 19,000 learner's permits in 2016, to say, we have this card and we see there's a gap where this information is not being provided in the book that you provide to the parents. So they're looking at getting this information into that book. So that would spread out to a very large audience if they're able to do that. So I'm going to turn it back over to Jenny to introduce our state team, and I look forward to your questions.
Wonderful. Thank you so much, Jen. That was incredibly informative. And a great lead-in to our first CoIIN state team presentation. We're going to hear from Lauren Casahagan, who is the lead for the Vermont Suicide and Self-Harm Prevention Team in the Child Safety CoIIN. And Lauren currently serves as the CDC assignee and lead epidemiologist to the state of Vermont's Department of Health and Mental Health, where she conducts public health research and surveillance on child and youth mental health, emotional and behavioral health, as well as risk factors that are associated with poor health outcomes like substance abuse. Lauren's going to talk to us today about the work that the Vermont Suicide and Self-Harm Prevention Strategy Team has been doing on testing to improve screening, coding, and referrals in emergency departments. Lauren?
Thanks, Jenny. So on this slide, on the left-hand side, you can see the distribution of injury type by age group. What's notable here is that almost 8 out of 10 injuries among 15 to 24-year-olds are due to either unintentional, intentional, or undetermined types of injuries. The leading causes of death as a percentage of all injury types are also notable, particularly firearm deaths to our youth here in Vermont, as well as suffocation or hangings and poisonings. We've also noticed some differences looking at the different types of emergency visits by the type of episode. So on the left-hand slide, suicidal ideation, there were over 1,600 events or episode types between 2010 and 2014 to Vermont youth in Vermont hospital emergency departments. You can see that there were almost the same number of self-directed violent events and about 990 medicinal poisonings. What's of concern to us in addition to just the overall magnitude and number of episodes, is that there's quite a few episodes of self-directed violence overlapping with medicinal poisonings. On the right-hand side of the slide, what you can see is that our crude rates of suicidal ideation, self-directed violence, and medicinal poisonings among 10 to 24-year-olds has increased from 2010 to 2014. So why are we interested in screening for suicide risk? If we want to prevent suicide, we need to move upstream from mortality to look at morbidity and the systems issues and social determinants that play a role in suicide. Suicide prevention is a priority for the community served by Northwestern Medical Center and Northwestern Counseling and Support Services. The health department and hospital community health assessment listed suicide as one of 6 priority health issues for this area. Suicide prevention is also a priority for Vermont. We have measured it in our Healthy Vermonters and are proposing to continue to measure it. We are piloting zero suicide in 3 counties, one of which is for Northwestern Medical Center. The Agency of Human Services has a suicide stat process that we started this year, which is an accountability mechanism to make sure that we're moving the needle on our data. We also have a CMS or Medicaid measure around reducing suicide rate and the Joint Commission accreditation measure for reducing suicide. Overall, we want to take advantage of this momentum nationally, statewide, and locally on suicide prevention. So why did we select this hospital? It's located in one of our zero suicide pilot counties. It is a small and progressive community hospital with hospital champions. The ED has an established relationship with Northwestern Counseling and Support Services for crisis services, and 1 full-time employee from NCSS works in the emergency department. We also have an expert screen team who is conducting work in the ED around alcohol and drug use. And our hospital data feed into 4 key data systems: hospital discharge, our all-payer claims database, our Medicaid claims, and our syndromic surveillance. In addition, NMC provides a unique opportunity to make sure that we know what we're collecting, analyzing, and interpreting. And we can improve the systems that detect and report the conditions, improve our hospital and emergency department practices and services, and it can serve as a model for other community hospitals in Vermont. We can also showcase our quality improvement work in an ED with other ED directors across the state in our monthly meetings and provide local level information on for our state's suicide stat. So what were our project goals? For the health information system staff, we want to increase accurate, consistent coding for suicidal ideation, self-directed violence, and medicinal poisonings. In addition, for our emergency department clinicians and staff, we want to increase that accurate and consistent coding. We want to increase the use of an evidence-based screening and assessment instrument and protocol, and we want to increase the use of referral process and protocols. For NCSS, we want to increase the use of an evidence-based screening and assessment instrument and protocol, and improve our ability of the clinicians and healthcare systems to provide clinical evaluation and treatment to individuals who are identified through screening and assessment as being at risk for suicide. So who was responsible for what? This is one slide that we used with the hospital to gain their buy-in for doing the quality improvement process. For the Vermont Department of Health, the very top tier, we identified money in terms of about $30,000 right now, as well as a project assistant to help with the work in the emergency department and obtained an IRB determination. We also observed current practices and validation, reviewed protocols and algorithms, provided oversight and technical assistance for the PDSAs, provided assistance with collecting and reporting the PDSA results, and provided training and assistance in locating specific training. For the hospital, we asked them to participate in the meetings, discussions about validation, participating in training, providing protocols and algorithms, reviewing or testing new protocols and algorithms, conducting and testing PDSAs, collecting the data, instituting change, and pulling data from their own systems. And we're all responsible for selecting the screening tools, developing and adapting protocols and algorithms, determining the content of the PDSAs, writing up what our results are in the forms of manuscripts, and presenting to peers at conferences or other venues. We also want to make sure that we disseminate our findings and the results of our work. So the next 3 slides are about our timeline. This all started with a hallway conversation right after the CoIIN kickoff in December of 2015. We posed the pilot project to the state epidemiologist in January of 2016. In the next 2 months, we had internal discussions about what would we actually do and how would we do it. And in March of 2016, we identified the first $15,000 in prevention block grant funds to help fund the pilot project process. And in April, we approached the hospital about the pilot project concept. And then from April to August, we spent a lot of time in meetings with the hospital and internally about how we would actually go about this and how we would get this done. Finally, in September, we entered into an agreement between the hospital and the health department to conduct the quality improvement work. And we also identified funding and hired a project assistant. And in October through December, we started conducting observations and documented our ED processes. What was the actual workflow and how did things actually work in the emergency department? In January of 2017, we determined how the expert screening in the ED could be adapted to include suicide risk screening questions. And we also determined which questions we were going to test. Finally, in February, we started our PDSAs. So that was a really exciting moment for us to finally get there after 14 months. This March, we secured an additional $15,000 in prevention block grant funds. And in March, the ED rolled out a brand new electronic health record system. And in April, we started initiating observation work on claims coding practices. And we're going to have a meeting in this month, in a couple weeks, to check on what our status is about screening and present our preliminary impressions and findings. And we've been invited to present at the Vermont Suicide Prevention Symposium in June. So the questions we're using are the Columbia Suicide Severity Rating Scale. The expert screeners asked the first 2 questions, and our NCSS crisis counselor asked the remaining 4. And we're looking at any ideation or suicide thoughts in the past 2 weeks. So our PDSAs look like this. We're testing from Monday through Friday, 8 to 6. We have a QI team on site, an expert screener, a crisis counselor on site, and the crisis counselor is not engaged with another patient, and it was under the old EHR. And all of our reasons are on the far right-hand side. We started to our next cycle when the new EHR system hit in the ED, and we had already determined that, yes, the expert screener could actually integrate the first 2 questions of the Columbia Suicide Risk Screener into the expert screening instrument, but we still had all the other questions we needed to learn about. We're now on our 3rd cycle where we have a crisis counselor dedicated to our project. We've refined the process for positive patients. We have an additional crisis counselor available to handle ED patients, and we have the new EHR system. And we have yet to answer all the other questions that aren't stricken out on the right-hand side. Our other concurrent cycle is that we have no QI team on site, but everything else is the same, and we're trying to learn if the expert screener can integrate suicide risk screening into his daily work. And we also have the crisis counselor also seeing if he can conduct and document suicide risk screening in his daily work. So far, we have 104 patients screened. Only 1 out of the 104 is actually to an individual less than 20 years of age. But as you can see, we've had 4 positive for one of the first 2 questions of the Columbia screener, 3 positive for both questions, 96 were not positive, and 1 refused. And then you can see the distribution of the 4 positive for one question and 3 positive for both questions on the far right-hand side. These are our lessons learned. Mainly, we found that the project had a lot of champions, and even in the best of environments, it's a slow process. Our major barrier was getting meetings with the decision makers. Providing money was a super easy solution. We used end-of-year prevention block grant funds, and that made a lot of gains. And this was providing support was an afterthought, and providing funds to hire the project assistant and providing that person to the emergency department also helped us. We don't think it would have been a project and that it might not have gained ED approval so easily had we not had a project assistant. Thanks very much, and we'll take questions at the end.
Wonderful, Lauren. Thank you so very much for sharing all of the great work that's been going on in Vermont around suicide and self-harm prevention. I want to now transition to the state of Indiana, where we will be hearing from both Jessica Schultz and Casey Ray. Jessica is the injury prevention epidemiologist with the Indiana State Department of Health, has been there since June of 2013. Jessica is a member of the Indiana Interpersonal Violence Prevention Team in the Child Safety CoIIN. And Casey Ray is the Child Passenger Safety Program Manager at the Indiana Criminal Justice Institute. She manages all funds, both federal and state related to child passenger safety, and is in charge of managing the network of child passenger safety inspection stations for the state of Indiana. Casey is a member of the Indiana Child Passenger Safety Strategy Team within the Child Safety CoIIN. And they will be sharing today about implementing an app for collecting data on automotive safety program checkups and the lessons learned and next steps. I'll hand it over to the two of you.
Thank you. So this is Casey with the Indiana Criminal Justice Institute. We've partnered with the Indiana State Department of Health to make this program what it is today. We also work with the Automotive Safety Program. They are the ones that actually initiated our electronic application and our work with the developers IN Cubed. So it's currently still in the implementation stage. There was a 4-page checkup form that was created by the Automotive Safety Program that all of our inspection stations are still currently using to collect data about the families, their income, race, ethnicity, where they're living, information about the child, and then we collect data on how the child arrives and then how the child leaves at that time. The form is very long and sometimes could get a little bit tricky to fill out, especially with new techs. So they started working with IN3 or IN Cubed to turn it into an electronic application. About a year and a half ago, ICJI took over the completion of this project. It's been very lengthy, but the application did go live in September of 2016. As of today, our office has provided tablets to each of our 114 inspection stations within the state so that they would be able to use the electronic application. We purchased all of those with funds from Title V and then our traffic safety grants from NHTSA. So what's not finished is IonCubed is creating a website that's going to host that data for us and provide us access to reports, be able to print those forms off if we need to, and be able to put some data entry in. So we did have the company create a demo version of the application. So anyone who wishes to check it out after today, you can go to the iTunes store and search for Automotive Safety Checkup Presentation, and you should find the application to look through it. So as I said, we're still very early in the stage. A lot of people do not like change. So we do have some of our technicians across the state that are very hesitant to switch to the electronic application. They're worried that'll slow them down. Some of them are worried they'll look stupid in front of the families, so they don't want to look bad in front of the families because they don't know how to use the tablet. So one of the suggestions we've given to them is they're practicing with their paper forms, entering them into the tablet, just getting a little more comfortable with the flow of the electronic application before they take it out to the cars. Unfortunately, iTunes requires a credit card on file in order to download even free applications. So that was the very first task we had to hurdle after we handed out all of our tablets, because a lot of the agencies didn't have a credit card to put on file, or their agencies wouldn't allow them to put their credit card on file to start an iTunes account. Quickly we discovered a simple fix of a $5 iTunes gift card would start them an iTunes account so they could download the free app. As I said, all of our agencies do have a tablet. We are finding that some of our larger hospitals that do inspections through their mother-baby unit as well as their pediatric unit and labor and delivery, it gets difficult for them. They can't really transport the tablet everywhere. We are working with our 2018 traffic safety grant funds to purchase some additional tablets to get out to some of those hospitals to make it a little easier on them. Some have complained that their grant reporting has been more challenging, so they don't want to use the tablets because it's not as easy for them to track how many inspections they've done and how many seats they've distributed based on the fact that each tablet holds everything that tablet's done. But if a technician within their agency uses a different tablet or their own personal tablet, it would take away their ability to see what was going on over there. But that issue will be corrected once the website is up and running, which we are very hopeful that that's going to be soon. Technicians are still getting down kind of a routine when they're dealing with multiple children. That's one of the biggest things that changed between the 4-page checkup form and the electronic application. You used to be able to do 2 kids simultaneously, side by side. Now you have to do 1 kid at a time. So some of the techs are having a hard time getting used to that. I don't think it's as big of an issue, because I noticed when I looked through the forms, a lot of people, when they did the side-by-side kids, they mixed up the information, and it kind of caused a lot of errors. So I think this will actually, once they get used to it and decide to just deal with it, I think it'll give us some better data and less errors. We're learning that anytime we want to change something to the application, that no matter how easy we think the update is, it takes a lot longer for the developers and Apple to actually make the change go through. So one of the biggest challenges is we had about 4 or 5 new agencies come on board this year, and it took about 5 weeks for the developers to update the coding in the app and get it approved by Apple in order for them to be added to the tablet and the application, and we are hoping to at some point find a little bit of a faster solution for that. So as I said, it is new. We've only been using it for a little over 6 months. But right now, all of those 4-page paper forms get mailed into my office, and somebody from my office has to enter them into a database. So we're currently holding on to approximately 25,000 inspections that have to be entered into the database once the website becomes available. And that's just going to be very time consuming. So the fact that there will be nobody actually entering data into the database because it'll automatically be there is going to be one huge success. While yes, I have the technicians who are still very hesitant to use the tablets, those who jumped right in and have been using it are just loving it, and they say it's really easy to use. They don't feel like they're making as many mistakes. They don't feel like they have to check up on some of their newer texts as often. Because there's just not as much room for error. It has automatic skip patterns. If you answer a question one way, you're not going to have an opportunity to answer a question that wouldn't go in the right direction. We'll get more accurate and up-to-date data. As I said, we're about 2 years behind on our entries, 25,000 forms, so we won't have that issue anymore. But Jessica is going to talk a little bit about that data.
All right. Good afternoon. As Jenny said, and as Casey just said, I'm Jessica Schultz. I'm the Injury Prevention Epidemiologist Consultant at the Indiana State Department of Health. I am not a certified child passenger safety technician, so I'm going to be focusing on how the app will allow for more accurate and up-to-date data from the checkups at car seat clinics, booster bashes, and permanent fitting stations. As Casey said, the app has a built-in skip pattern that can assist the techs filling out the forms in the app by leading the user to the appropriate questions based on the previous answers, and adding conditional branching or a skip pattern can make the data collection process quicker and smoother for the user, and also then for the parent or caregiver at the checkup. And this also creates less room for error in the input. The app can also fill in answers based on previous answers, such as calculating the age of the child in days, weeks, months, or even years based on the inputted date of birth. We also know that digital data capture at the source can greatly reduce transcription errors that might occur when entering traditional paper forms into the data collection system. As Casey said, the system is also creating a website to be able to host the data that might prevent some of the data to be lost in transit. The information will be the same as collected on the paper form, but we know that we can be able to track at a quicker rate the household income, education level, ethnicity, and race. And I'm going to walk you through a couple of the slides, or a couple slides that have the snapshots of the app. Let me get this button. So the first page actually allows you to select the language that the app user can select, and then the second page allows you to input your name and your certification number. So this is actually once you're into the actual checkup information, you can capture a lot of information on the parent and caregiver, and also select if the parent or caregiver chooses not to answer one of the questions. You can also collect a variety of the demographic information we talked about on these next couple slides. So having the age of the parent and the caregiver, so some of their demographic and ethnicity, race, and then important for some of the reimbursement and the needs of the family, some of the income and how many people live in the household, as well as the level of education. So by being able to collect this information at the source, we're able to reduce some of the errors in transcription and then have the data more timely and a lot more quickly to be able to use them for grants, for program management, and that sort of thing. Preston Harness in my office is a certified child passenger safety technician, as well as working closely through the CoIIN with Casey and some of our other partners, and this is his contact information if you would like to get a hold of him. I think now we're moving on to questions.
Indeed. Thank you so very, very much. Such terrific information, and I apologize, Jessica. I neglected to note that not only are you a member of the interpersonal violence prevention team, but also of the child passenger safety team, as Indiana has both teams within the CoIIN. So thank you so much for sharing that. And we do want to move to a few questions that have been submitted as we sum up. And one that came in was, how do you measure outcomes for small programs? I know in both of our team presentations we were talking about a broader implementation process, but I know you're also working on smaller levels, and Jen, I know from other teams within the CoIIN that we have several examples of that. So I'll throw it open to the full presentation group.
Thanks so much, Jenny. This is Becca. I'll jump in there. So I think it's really important to keep in mind that small programs exist within a larger context. So the chances are there's many small programs who are working towards the same goal. One of the things that the CoIIN is promoting is this concept of a systems approach. So if you're thinking about how your small program aligns with other small programs or interacts with other small programs, that's where we can start to see the movement towards actually reducing rates of injury-related hospitalization, deaths, and ED visits. So I think those long-term evaluations are very important, but keeping in mind the overall trends and understanding all of the components of the system across your entire state is equally important.
Great.
And
Does anyone else have any? Oh, go ahead.
This is Jen jumping in just to add to that. You also would think about how you operationalize the measure. So I think that if you're really working in smaller programs, or if you're working perhaps in one county, then you could look at that progress measure data and outcome measure data for that particular geographic region, for that particular population. So you could do that early on to start to see signals of improvement and see where things are moving. So how you operationalize your measures is going to be important.
Great. A question, another question that just came in was, I'm not sure I actually understand the question. I apologize. Alexandra, if you want to restate your question, I'm not quite understanding the way that it's phrased. And we have just a few minutes, but if you can restate it, I might be able to get to it. Yeah.
I think I can interpret that one. So
okay, great.
It looks like Alessandra is asking about balancing measures and unanticipated consequences as part of a measurement strategy. So balancing measures are measures that track whether or not you have a negative outcome as well as an improvement. So if you're looking at a minor change to your program and you are expecting the results to be one way, you would, for example, when we started working on concussions and raising awareness around traumatic brain injuries and sports concussions, we were looking at the awareness campaigns that were out there, and we wanted those numbers to increase. But a balancing measure that we also had to look at was the rate of emergency department visits. And when that outreach work really began, we saw ED visits increase dramatically. So if we were not taking those other measures into consideration, the number of people who were actually receiving the services that they needed, the number of people who were aware of the consequences of sports concussions, et cetera, we might think that our program was a failure because we were seeing such a large increase in emergency department visits. But in fact, it was a success. So that's what balancing measures are. We do, in the measurement strategy for the CS CoIIN, we have those three layers of data, and we do encourage balancing measures so that you're looking at not only what your program is doing, but some of the unintended consequences of it. And we have seen that that is, especially around suicide and self-harm, it's a very important consideration to take.
Excellent. Thank you so much for diving into that, Becca. Unfortunately, we are at the end of our hour. I did have a couple other questions, but we've just run out of time. This has been an incredibly thorough and informative presentation today, and I really want to appreciate all of the presenters. I want to let folks know that the Children's Safety Network has another webinar coming up on May 31st addressing distracted driving amongst teens and how to prevent it. So please be sure to register for that. Here's the link here, or you can also find that on our website. And we thank you all very much for joining us today. Please do take a moment to fill out our short evaluation as you exit. We look forward to seeing you at the next presentation. Thank you.